Hi, good evening. Welcome to our presentation tonight on Lennox-Gastaut syndrome. This is the Ask the Expert series provided to you by the Epilepsy Foundation of Connecticut. My name is Monica Anzalone. I'm the Director of Programs and Services at the Epilepsy Foundation, and I'm going to be moderating the presentation for tonight. Just want to share with you, for those that are not familiar with the Epilepsy Foundation, our mission is to support people that are impacted by epilepsy through advocacy, education, programs, and connections to ensure that they can live their best life. We ask that you please keep yourselves muted, although I think everybody is muted because we're in webinar form. But you can feel free to type your questions in the chat section, and we will be sure to answer them at the end of tonight's presentation. And the doctor is happy to answer questions concerning tonight's topic, but please keep your questions pretty general. We don't want to be asking for personal medical recommendations at this time. Okay, so we're going to learn a little bit about our presenter. We are joined tonight by Dr. Lila Worden. Dr. Worden is a pediatric epileptologist and neurologist at Connecticut Children's. Dr. Worden's areas of interest include epilepsy, ketogenic diet, and other dietary therapy for epilepsy, as well as neonatal seizures. So at this time, I am going to hand over controls to Dr. Worden.
Okay.
We're going to get started.
Thank you so much, Monica, and thank you for the invitation to speak tonight. I'll be talking about Lennox-Gastaut syndrome, which is an epilepsy syndrome which starts in childhood but continues into adulthood. And it's one of our more common epilepsy syndromes, and it can be a challenge to treat. We'll do a whirlwind tour today about it, and again, I'm happy to answer any questions that you have at the end. As Monica mentioned, I am one of the pediatric epileptologists at Connecticut Children's. I did also just want to mention that I lead our ketogenic diet program at Connecticut Children's, where we see both children and adults with for ketogenic diet therapies. So it is not just restricted to pediatric patients there as well, because I know that it can be a challenge to find adult ketogenic diet centers. Oh. There we go. Okay, so to start the talk, I'd just like to mention that I don't have any financial disclosures relevant to this talk. I will talk about some non-FDA approved treatments, however, so what we think of as off-label, which is a very common thing in the world of pediatrics, but less so in adults. And the outline of our talk tonight is going to cover what is Lennox-Gastaut syndrome, how do we define it historically and also practically, what causes Lennox-Gastaut syndrome, also known as LGS, what are some of the non-seizure considerations about this syndrome? We are all here, of course, and united because of seizures. However, there's a lot of other things to consider with LGS. And what are some of the treatments with LGS? What are some of the current treatments, as well as what are some of the upcoming treatments to consider for patients? So let's take a step backwards in time and figure out where the name came from. So who are Lennox and Gastaut? Dr. William Lennox was an American neurologist who in the 1950s had described a triad of what he said, quote, mental deficiency, polymorphic seizures, and diffuse slow spike and wave on EEG. He was not the first one to mention the diffuse slow spike and wave, but he was the first to put those three together into a characteristic syndrome. Now, about 15 years later, came up Henry Gastaut. So Henry Gastaut was a French neurologist who in 1966 more formally described the criteria that we now know as Lennox-Gastaut syndrome. He actually called it Lennox syndrome, because Lennox did describe it about 15 years earlier, but it really came to prominence as its own syndrome in the 1960s, because at that time, the dominant thinking in the field of epilepsy was actually quite a bit in Europe. So a few years later, the Lennox syndrome became more commonly known as the Lennox-Gastaut syndrome that we talk about today. And what is the definition of Lennox-Gastaut syndrome? Well, Lennox-Gastaut syndrome is a childhood onset severe developmental and epileptic encephalopathy. What is that? What is a DEE, as we commonly refer to it? A developmental and epileptic encephalopathy is a condition where the underlying cause, whether that's a structural difference to the brain, like a brain injury, or a genetic cause, that difference causes both difficult to control seizures and frequent EEG abnormalities on the brainwave study, as well as the cause leading to developmental delay. Now, there's a third piece of the pie that's different about developmental and epileptic encephalopathies, however, that the seizures and the frequency of the abnormal electrical discharges on the EEG also leads to developmental delay and later intellectual disability. And that's the hallmark of a developmental and epileptic encephalopathy, of which LGS is one. What is a more practical definition of LGS? Well, there's four things that we think about. First of all, patients have multiple seizure types, which we'll get into in a minute. They have particular EEG characteristics, the most common being generalized spike and slow wave activity, as well as a second called generalized paroxysmal fast activity. The third is that there's developmental delay and later cognitive difficulties, which we now term intellectual disability, which is the new, more appropriate term for mental retardation. The fourth is that there's onset in childhood years. This is a pediatric disorder that people then grow up with. Now, the seizures in LGS are what we term drug-resistant seizures, or also called intractable or refractory, meaning that we've tried at least 2 different seizure medicines and people continue to have seizures. There are many, many different seizure types that people with LGS can have, but here are some of the most common ones. Tonic seizures, also called stiffening seizures, are some of the most common ones that we see. And the hallmark of LGS are nocturnal tonic seizures, so stiffening seizures at night. However, that seizure type is not pathognomonic or exclusive for LGS. They often frequently have atypical absence seizures. What makes it atypical? Well, from a neurologist perspective, a typical absence seizure has a very classic EEG pattern of 3 abnormal discharges per second in the whole brain, associated with staring and pausing of behavior for 5 to 10 seconds. A typical absence seizure is a slower pattern that still involves the whole brain, but can go on for much longer, many minutes, and sometimes people can have that even for hours. They also have something called atonic or drop seizures, which can be very disabling from a safety standpoint, particularly if it happened when you were in a place like the top of the stairs. And then people with LGS very frequently have other seizure types, including myoclonic seizures, whole body quick jolts, generalized tonic-clonic seizures, which we all know of and are referred to as grand mal seizures. Those are whole body stiffening and then shaking, and then also focal seizures or spasms. I mentioned that there's 2 EEG hallmarks of a patient with LGS that are very commonly associated. The first is called slow spike and wave, and this is what it looks like. You see discharges throughout the whole brain, from the left side all the way to the right side, and they are occurring about 1 time to 2 times per second. This is an example of one of my patients who has LGS, and an example of slow spike and wave activity. We also see from the same patient generalized paroxysmal fast activity, meaning again, whole brain, sudden onset, faster frequency activity, so up and down many, many more times per second. And those are two hallmarks of the EEG pattern that we see in LGS that are part of the criteria. So how common is LGS? Well, it's pretty rare. Uh, doesn't feel rare to us, but it is not very common. So epilepsy overall in the general population is about 1%, sometimes up to 2% at certain ages in children. LGS of that is probably about 2 to 5% of patients with epilepsy. The studies looking at how common it is really range from 1% of epilepsy patients up to 10%. And interestingly, there is a slight male predominance, but it's actually really unknown why that is. Now, the average age of diagnosis is 3 to 5 years old. And it's very hard to make the diagnosis before about 2 or 2.5 years. And why is that? Because some of those very important EEG patterns that we look for to help us make the diagnosis don't show up until that age. However, when you ask families, when did really all of this start? When did your journey begin? Well, actually, it started much earlier for most people. It started at 1 years old, maybe before then they started having seizures. The developmental delay started to get a little bit worse. And then maybe they didn't get the LGS diagnosis until they were 4 or 5. And why is that? Why is there that gap between when things started and when you got the LGS diagnosis? Well, LGS is the end result of multiple different paths. And people don't start having epilepsy with LGS, it evolves into LGS. And those criteria happen in a staggered fashion. So maybe you start having focal seizures at the age of 1, and then you start getting developmental delay, and an EEG shows generalized spike wave, but you don't get a second seizure type until you're 3 or 4. And then at that point, you might have all the EEG features over time and multiple seizure types over time to meet the criteria for LGS. So it is a journey to LGS and results in that, but it's not often clear at the beginning. LGS is an umbrella term that, again, is the end result of multiple different pathways. So what are the causes of LGS? So the causes of LGS can be variable. One of the most common things that we see is brain malformations. So the brain was formed incorrectly in the womb, and there can be too many folds and wrinkles, something called polymicrogyria. There can be not enough folds and wrinkles, something called pachygyria, or when it's very extreme, something called lissencephaly, where your brain is smooth. There can be a brain where the brain cells are disorganized and didn't correctly form in layers where they're supposed to go. That's called a cortical dysplasia. Those are examples of some brain malformations that might lead to LGS. Severe brain injury is another big bucket that we see. These are often babies who've had a severe hit to their head in early life. Either they didn't have enough oxygen either before or around the time of birth. That can cause them to have severe brain injury. Maybe they had a stroke around the time of birth. Maybe there was an accident, for example, and they had a lot of bleeding inside their head. We also know that there are genetic variants that underlie a lot of our LGS as well. And these can be by themselves and have a normal picture of their brain, or the genetic variant can lead to extra abnormalities on what their brain look like. The common denominator amongst all these causes is that patients develop drug-resistant epilepsy, which over time meets the criteria for Lennox-Gastaut syndrome. So how do we separate these causes? So we often think about LGS as secondary or symptomatic. They're not terms that are used very much anymore, but what they essentially mean is that you have LGS due to an identifiable cause. And that's about 75% of LGS cases. Either we know that you have bad diffuse brain injury, meaning all over on both sides of your brain, or you have a known genetic disease or a metabolic disease which contributes to your seizures and your LGS. About a third of patients have a history of drug-resistant infantile spasms, sometimes referred to the prior name of West syndrome, which is the combination of infantile spasms, developmental delay, and a special EEG pattern that's associated with it called hypsarrhythmia. When we are trying to figure out why somebody has LGS, we are doing these things to answer that question and to figure out how we can best treat this patient and make sure they truly do have LGS and not something else treatable in a different fashion. So a brain MRI to look for malformations and to look for signs of old injury. We're doing metabolic testing to see if there's a reason why somebody has a metabolic disorder that leads to seizures. That can be an LGS mimic. We're also doing genetic testing to try to answer that question of why. About 25% of the time, we end up in this other category that's called idiopathic or cryptogenic. And essentially, idiopathic means we're just not smart enough yet in our medical knowledge to know why. And despite our best testing, this is still about a quarter of the cases of LGS. There has not been a re-review of the split between secondary or symptomatic LGS and idiopathic LGS in the past 10 years. It's possible that that number, that 25% number, is actually a little bit lower because we are now doing genetic testing much more broadly than we were in the past. And there are broader types of genetic testing available. So perhaps that number is a little bit lower with more sophisticated genetic testing, but that's still the best estimate that we have. So what happens in the brain that causes LGS despite multiple different etiologies? The answer is nobody really knows. And there's two hypotheses that have been floated out there. None of them have particularly great evidence behind it. The first is that there's an excessive connection, so two free-flowing excitatory pathways of firing too much and too much of a connection between both sides of the brain in the front of the brain early in life. Why that is, it's a little unclear. The second hypothesis is a neuroimmunologic cause, because one study found that patients with LGS have much, much higher rates of having a particular immunologic cell marker on the outsides of their brain cells than people who don't have LGS. Why that leads to LGS, also not explained, but it was an association that was found. However, when that study was tried to be replicated, they could not find the same result. So it's a little bit unclear still, and part of our challenge in LGS is that we don't know, and we don't have an animal model to explain that to help our research. So let me shift gears a little bit and talk about some of the non-seizure comorbidities, because LGS comes with seizures, of course, but it also comes with many other things that impact somebody's quality of life. And the LGS Foundation, which I'll direct you to at the end, has a particular term for this called LAD, or LGS Associated Disorders. The first and one of the biggest is intellectual disability. So when a child is 1 or 2 or 3 years old, we use the term developmental delay. But when they get above the age of 5, that term actually shifts to more appropriately be called intellectual disability. So they have thinking problems. And the reason it makes that transition around the age of 5 or 6 is because that's the age at which we can do formal IQ testing with standardized tests. The intellectual disability associated with LGS is typically in the moderate to severe range, but it's not across the board, actually. So there are patients with LGS who have normal or borderline normal IQ, and that's about 8 to 10% of patients. The patients who do end up having normal or borderline normal IQ will often be older when their LGS starts, so 9 or above instead of 2 and 3. And they will often be in that cryptogenic category, meaning that we looked at all of their MRIs and genetic testing and metabolic testing, and we still don't understand why they have LGS. Going along with intellectual disability are things that commonly co-occur in other conditions as well, such as autism spectrum disorder, behavior challenges, which can come out as aggression or rage attacks, particularly in people who have communication difficulties, and then attention problems, problems with focusing and learning in school. Motor problems are also seen at a higher rate in patients with LGS compared to other types of epilepsy. So, and adults with LGS may have difficulties in the muscles controlling their swallowing ability, as well as muscles controlling bigger movements like walking. The swallowing abilities can be related to something called low muscle tone, which is meaning floppiness. So their muscles are a little bit too floppy. And we also see in the setting of children who have swallowing difficulties that they can be drooling more. Now, some of this could be medication related as well, as one of the most common medications that we use for LGS, called clobazam, is known to increase drooling. So there's a lot of factors that we think about here. Balance issues and walking problems are also part of the problem. Is it that our seizure medicines are making us tired, giving us a balance problem, is the dose too high, also contributing to balance problems? Underlying that, though, we also see that coordination in general is a little bit worse in patients who have LGS. Now, the worst thing to do is not use it. And why is that? If you don't use your muscles, they just get weaker, and disuse can lead to worse problems than you have already. So, for example, if walking is hard and it's easier to just be in a wheelchair all day, well, you can have complications like low bone density because your bones aren't getting enough resistance from standing, and then you can get spontaneous fractures and other health problems. If your swallowing muscles aren't practiced because it's easier to be fed through G-tube, that is something that can worsen your strength and ultimately lead to something like aspiration pneumonia. So practice, 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 despite the challenges. We do know that LGS is associated with early mortality, so patients with LGS die younger. When the diagnosis of LGS is given, there's a 3 to 7% mortality within 10 years of the initial diagnosis. And the average lifespan of a patient with LGS is 43 years, although there's quite a broad range for that interval, plus or minus 10 years, meaning one standard deviation above or below 33 to 53% captures about 50% of patients with LGS. Now, people who have intellectual disability do die early across the board from other causes, but patients with LGS have shorter lifespans than those patients just with intellectual disability and without LGS. So why is that? Well, there's a few things that happen in patients with LGS pretty commonly that don't happen as much in other patients. First of all, injuries and accidents is a big cause of potential mortality. In particular, if you're having something like drop attacks, where you suddenly fall to the ground and it's in a place where you might be hurt. At the top of the stairs, for example, on a place where there's concrete instead of carpet underneath you. Aspiration pneumonia is a big cause of morbidity and mortality in patients with LGS. Often those swallowing problems can worsen over time, as I mentioned, and seizures themselves can lead to some of that saliva or drool going back down into the lungs. Over time, their lungs get weaker and weaker, and recurrent infections can be a cause of death. And the third cause that is common for our patients with Lennox-Gastaut syndrome is something called SUDEP, or sudden unexpected death in an epilepsy patient. Many of us have heard of this. Many of us fear this as epileptologists, as well as families and caregivers to patients with LGS. But it is a unexplained but potential cause of death for all patients with drug-resistant epilepsy. And patients with LGS in particular have seizures that are hard to treat despite trying multiple medications. So they are at higher risk of SUDEP than other patients. Sleep issues is another common extra non-seizure comorbidity that we see in LGS. The exact rate of sleep difficulties is a little bit hard to pin down. It's actually not really known, but sleep difficulties are across the board complained about. They are things like trouble falling asleep, trouble staying asleep, restless sleep, and it's a little bit unclear if this is a chicken or an egg problem. Does an abnormal EEG with a lot of slow spike wave and a lot of extra abnormal discharges, in particular in sleep, does that then lead to awakenings and poor sleep? Or is it the opposite? That you are sleeping poorly, and because of that, you are waking up a lot and having lots of times where you're having seizures because of that transition between wakefulness and sleep. So it's an area of potential research that needs to be looked into. Now we'll shift gears a little bit and mention a few things about some of the therapies that we use in LGS and what are some of the up and coming therapies too. And this is just to remind you that LGS really is this umbrella diagnosis. Sometimes other people refer to it as a bucket. There's lots of things that end up in that bucket. And the therapy is not one size fits all. What is the cause of your LGS? Is it something that we can understand? And how does that help us guide what therapies are available to you? So the first option for therapy is anti-seizure medicines. And once you end up with that diagnosis of LGS, if you haven't already been on valproic acid, also sometimes referred to as the brand name of Depakote, that tends to be the initial treatment in most people. There are a certain number of medications that are specifically approved for LGS. There's about 8, which you can see here: lamotrigine, rufinamide, topiramate, clobazam, cannabidiol, fenfluramine, felbamate, and carbamazepine. There are actually over 30 anti-seizure medicines, and really any patient with LGS is likely to be on multiple medications, and even if it's not specifically approved for LGS, it's likely to be effective and be reasonable to try. I mentioned that most patients will be on more than one medication. What people have shown in LGS and in other drug-resistant epilepsies is that usually 4 or 5 medications is not better than 3. 2 or 3 is where it maxes out on the benefit, and sometimes it's hard to pull that back because there are always fluctuations. But if people are on 5 or 6 medications, we often say, okay, which ones are the most effective, and can we get a similar amount of seizure control on fewer medications? Because it might reduce some of the side effects that people have. One of the second treatment options is diet therapy for LGS. Now, as I mentioned, I'm the director of our ketogenic diet program at Connecticut Children's, and I'm a firm believer in diet therapy. The diet therapies come in a few different flavors, but all of them revolve around this idea of a very, very high fat diet and very low carbohydrate diet. And there's about 4 different flavors: the classic ketogenic diet, the modified Atkins diet, also called modified ketogenic diet, the MCT oil treatment, and the low glycemic index treatment. There is a better than average responder rate in patients with LGS who try diet therapy than other people with epilepsy that is non-LGS. Overall, if you looked at all comers, so all different types of epilepsy, about 40 to 50% of patients will have be a responder, which we define as at least a 50% reduction in seizures. In Lennox-Gastaut syndrome, it's more like 60 to 70%, so better than average responder rate in LGS to diet therapies. People also report improvements in things that can be very important to quality of life. So they report improvement in alertness and attention and cognition. What are the differences between these different types of diet? So this is a picture of the amount or the percentage in each of these diets that you get calories from fats in blue, the protein in red, and carbohydrates in green. So you can see on the classic ketogenic diet, you're about 90% of your calories or your energy from fat. And on the classic ketogenic diet, you have to weigh and measure everything on a gram scale. On the MCT oil ketogenic diet, you're about 73% fat, and most of that fat is coming from MCT oil, which originates from coconuts mostly. The modified Atkins diet or modified ketogenic diet is kind of like a light version of the classic ketogenic diet where you don't have to weigh and measure everything on a gram scale. It's just using household measurements, for example, a quarter cup or a teaspoon, and you count carbohydrates and try to meet a certain amount of fat each meal. And the low glycemic index therapy is perhaps the least restrictive of all, where only about 60% of your calories come from fat. The low glycemic index treatment revolves around making carbohydrate choices that are low on the glycemic index scale. The glycemic index tells you how quickly your blood sugar spikes. And so a food with a low glycemic index has a slow release of sugar, and one that is high spikes very quickly and goes down very quickly. All are potential options for patients with LGS, but the most common would be the modified Atkins as well as the classic ketogenic diet. So I did want to touch on a few devices as well. So neurostimulation or neuromodulation devices are kind of the next big front in patients who have LGS. And there's three different types: the VNS, the DBS, and the RNS. The VNS is a battery pack that's inserted underneath the chest, where you might find, for example, a defibrillator, or somebody who has a pacemaker also has the battery inserted under the chest. And then wires go underneath the skin up to a nerve in the neck called the vagus nerve, and wires wrap around that vagus nerve and send signals to the brain. The other two, the DBS and the RNS, have implantable electrodes that go into the brain itself. The vagus nerve stimulation is the only device that's approved for LGS. And what is the responder rate? So about 50% of patients will have a 50% seizure reduction. That's similar to trying a medication, but what we don't know about devices is, okay, what half are you going to be on? Each patient with LGS, we can't look at you and say, okay, you're going to be the 50% responder or you're going to be the 50% not. It can take about a year to see the effect of seizure reduction from the VNS, but over time it does decrease or SUDEP risk if it's helpful and you have it for multiple years. 2 to 5 years out, it can start decreasing SUDEP risk. The two devices that are up and coming are the deep brain stimulation and the responsive neurostimulation. There was a trial with the deep brain stimulator where they implanted the electrodes into the thalamus. The thalamus is this structure here that's deep down in the middle of the brain. It acts as a relay station for signals from outside the brain, way out here, that go down to this relay station in the thalamus, and then can go back up to the cortex, so the outside of the brain, or it can go down into the body. So the implant goes into something called the central median nucleus of the thalamus. And again, about 50% of patients had a 50% reduction in seizures. The responsive neurostimulation has a trial ongoing right now, but there's early reports from centers who are using the RNS that the response rates are similar. Oops. So what else is an option for some patients with LGS? Well, surgery remains an option, and epilepsy surgery in LGS is often thought of as palliative, meaning that it's not curative. It's when you have surgery, you're not going to make your seizures go away completely. However, it can definitely improve the quality of life for patients if chosen appropriately. Resective surgery, where part of the brain is taken out, is available for a few cases of LGS. It really depends on what the cause is here. So if there is a difference in the structure of the brain, and that is only in one half of the brain, such as a tumor, for example, in tuberous sclerosis complex, which is a neurogenetic condition that sometimes ends up like an LGS type picture. Or, for example, if there's a big brain malformation, but mostly in one half of the brain, a resection is a possibility here. More often, surgery discussions in patients with LGS end up with something called a disconnection surgery, where we separate the two halves of the brain to prevent signals from traveling across. And there's two different types of surgeries we think about. The first is a corpus callosotomy, where the corpus callosum, which is kind of like an information highway connecting both sides of the brain, we disconnect the corpus callosum. And that corpus callosotomy in particular is very good at stopping drop attacks, where the seizure suddenly hits you and you fall to the ground. That can mean a big improvement in quality of life for somebody who is having those, for example, being wheelchair bound to be able to walk again. The other advancement in corpus callosotomies is that we used to do them all as an open procedure, meaning that you would open the scalp and open the skull. There are some centers that are now doing something called LIT, or laser interstitial thermal therapy, where they use a laser and guided by MRI and are able to do it with the scalp closed. The precision is not as good, and sometimes there are some fibers that are not disconnected completely, but it is much less invasive than an open corpus callosotomy and is another option for patients to think about. The other type of disconnection is called a hemispherectomy, where you do a corpus callosotomy, but also take other structures that are in the middle of the brain and separate them. And that is a very helpful surgery if, again, people have one half of their brain that has a big injury, but the other half is okay. And lastly, patients with LGS are some of the first who have availability to enroll in clinical trials. So while seizures may be hard to control, there are a lot of options out there if you're open to thinking about clinical trials. So this was from clinicaltrials.gov, which is the website open to anybody to look to see what clinical trials are available. These are some of the ones that are actively recruiting right now. For example, this first one is looking at surgery versus medicine for LGS. This one is looking at RNS for LGS. And these two are looking at an experimental medications, two different experimental medications for children and adults with LGS. When we think about therapies, we also don't want to forget about all of those other non-seizure comorbidities that are associated with LGS, and think about the care teams that need to be involved. So, for example, does the patient with LGS have excessive drooling? Should we have ENT get involved to see if something like Botox or medication to reduce drooling might be effective? Let's optimize their lung health to prevent aspiration pneumonias and get pulmonology involved. Or maybe it's the GI team because they have swallowing difficulties. like to try to keep people's strength up and their balance up so that they have fewer injuries that are not related to seizures. So physical therapy, occupational therapy, particularly if there are sensory differences that are leading to these aggressive or behavior issues, neuropsychology testing to make sure that somebody is getting adequate school supports. And then, of course, financial resources. LGS is expensive for families, including families who do have insurance. So, thinking about secondary insurance, thinking about private foundations that can cover some of those expenses that are very necessary but not covered by medical insurance, such as things like shower chairs and baby gates so a patient doesn't fall down the stairs. Respite care is also an important piece here and hard to find. However, something that I always like to bring up every once in a while. You need to take care of yourself as a caregiver because this is a marathon and not a sprint. So there are lots of reasons still to hope in LGS, and despite this being a lifelong neurodevelopmental disorder that involves difficult to treat seizures, there's a really amazing community of people out there, and connecting with them can be very helpful in coping with the everyday differences and struggles that people have. There are many new medications who are on the horizon. I just showed two of them in the clinical trials, but there are multiple in addition to that as well. Really, all medications that are used for seizure medicines are potential options for patients with LGS. We also know that neuromodulation devices are offering a new alternative to surgery. They're currently off label. There are some trials that are out there, but it is possible to get it off label as well for patients with LGS. And we also know that overall, surgery is becoming safer and less invasive as there are other options like this lip therapy or laser interstitial therapy. So there are ways to treat the seizures that are not medications that weren't possible even 5 years ago. And the last reason to hope is that even though seizures will never go away in patients with LGS, even a modest reduction in seizures can lead to a significant improvement in quality of life for people with epilepsy, and in particular for their caregivers as well. So with that, I want to say thank you for your attention during this talk and point out the LGS Foundation that can help guide families in terms of treatment options, as well as provide kits to families who are recently diagnosed. And then I just wanted to mention that the November 1st is International LGS Awareness Day. So that's something to keep in mind. And certainly Monica can also help connect patients or families who are interested in connecting with other families in Connecticut with LGS. That's something the Epilepsy Foundation of Connecticut can help to do. So thank you very much, Monica. I'm all set, and I'm happy to take any questions if anyone has them.
Thank you. And yes, please type any questions in the Q&A or the chat at the top or the bottom of your screen. And I feel like you answered a lot of my questions as you started presenting. So thank you. It was very comprehensive, I thought. And one of the questions that came up for me, in thinking, I know that for epilepsy patients, oftentimes, because we know epilepsy is a spectrum disorder, it is quite different from one patient to the next. Is that even still the case for a syndrome like Lennox-Gastaut? Is it still pretty different from one patient to another that has this diagnosis, or are there more similarities than differences?
There are probably more similarities than differences, in particular over time. So to have this syndrome, patients do have those EEG patterns. They have multiple seizure types. They have intellectual disability or developmental delay if they're still younger. What can vary a little bit is the comorbidities that can be associated. So patients, for example, who have a big injury to their brain from lack of oxygen, when they were very young. Those patients may have bad cerebral palsy, for example, and be wheelchair bound or fed through a G tube, a gastrostomy tube in their stomach. But then there are other patients with LGS who have LGS but are more independent, who are walking around, who are in fact running. I have an adult patient who I saw for ketogenic diet therapies who was in the Special Olympics and who was a very fast cross-country runner and who had intellectual disability, but more on the mild spectrum. And she had a cortical malformation, so a brain malformation as the etiology of that. So I would say the comorbidities do depend a little bit on the cause. There are some causes, such as a big brain injury on both sides of the brain, where people are in more similar buckets, not walking, not talking, but then there is a bigger spectrum. Overall, though, LGS, I would say, in terms of the seizure types and the seizure control, are more similar than different.
Mhm. And I get one of the questions someone had was, can you just explain a little bit more about the genetic testing for LGS? Maybe what that would entail?
Yeah. I think the standard now is to look at something called a microarray, as well as a genetic epilepsy panel. So you're looking at a panel looks at a smaller number of genes. So depending on what company and what panel you choose, it can look at anywhere between 300 and 1,000 genes that are just related to epilepsy. And a microarray is a different type of genetic test that takes a more zoomed out view, and it doesn't read every single gene, the gene being kind of the important parts of your DNA that actually code for the proteins for how our body is made. A microarray takes a zoomed out view and just looks for any chunks that are deleted or duplicated. So it looks for parts on your DNA where there's too many copies, like if there was a duplication, you would have an extra copy, or if there's a deletion, meaning instead of two copies, because you have a copy of DNA from your mom and one from your dad. So instead of two copies, you only have one. So that's what a microarray is. A epilepsy panel looks at just genes that are related to epilepsy. And then the third test that is more and more important, and that we do a lot in pediatric neurology, but if you're a patient with LGS and you're 30 or 40 years old, you actually probably never had this test. That test is called a whole exome sequencing. And instead of looking at 300 genes that are related to epilepsy, you're looking at all 20 to 25,000 genes that we have, and it's looking to see, are there any spelling differences that might contribute to why you have seizures and why you have developmental delay or brain malformation or intellectual disability. So the whole exome testing has really been the big difference in the past 10 years and is covered by most insurances. It is something we can often get approved, and it is the game changer in terms of thinking about why somebody has epilepsy. Now, we're also, particularly if their brain structure looks okay, like on a picture of the brain, we're also thinking about what are some of those metabolic disorders that might lead to a pattern like LGS. So these metabolic disorders are just a category of lots of different types of disorders where somebody has problems breaking down and using fats or carbohydrates or proteins. And that can also lead to a picture that can be a mimicker of LGS, so seizures and developmental delay, but is treated in a very different way. And we want to make sure that we recognize that.
And with the medications that you shared were commonly prescribed for your patients with LGS, how would you go about determining which ones to try first? And one of the attendees mentioned the cannabidiol oil and the
Mhm.
side effects maybe being less than some of the others. How would you recommend, that over another?
Part of that depends on the patient in front of me
Yeah.
as well. So valproic acid tends to be a good medication to start with and is often one of the first line recommended therapies for LGS. Why is that? It's well tolerated by a lot of patients. It is one of the more effective medications. And then added onto that, people will go in different directions. So often, if you continue to have seizures with valproic acid, you will add on a second medicine. Some people choose lamotrigine, some people choose clobazam, some people choose rufinamide. And I would look at the patient in front of me and try to figure out, okay, what are the most bothersome types of seizures? Is it that this patient is having falling seizures or drop attacks? Rufinamide has been shown to be a little bit better for that than other seizure types, so I might choose rufinamide in that circumstance. Are they having any mood or behavior issues? Lamotrigine might be a good option for that because, for example, lamotrigine can be a little bit of a mood stabilizer. Clobazam as well is something that is sometimes insurance is push back a little bit if we haven't tried X, Y, and Z first. So it can depend a little bit on the patient in front of you. So when we are thinking about medications, we are thinking about that. Okay, what do we think might be the best medication? Is it in a formulation where the patient can take it? For example, some medications are only in pills and you can't crush them, otherwise it reduces the effectiveness. Well, that's not going to work for a 4-year-old. Okay. And then the last thing that we think about, which we often are not aware of ahead of time when we're prescribing, is okay, what is the insurance coverage for this? And is this insurance denying it because they're asking us to cover something else first?
Mm,
And some of
right.
these medications require pretty stringent blood work as well. And so is this a child where it's going to be difficult to get blood work?
Mm,
Should we try something else first?
yeah, yeah. And with the Epidiolex, are you
Mhm.
finding the insurance companies are not wanting to pay for that?
They will pay for it with patients with LGS because
Okay,
it is one of the approved
right.
indications.
Okay.
And when drug companies do trials, they will often do it in patients who have frequent seizures first. So LGS syndrome or Dravet syndrome, for example, are two different types of seizure syndromes where people have very frequent seizures. And why did they study in those populations? Well, first of all, the risk benefit ratio is different. You're willing to take a bigger risk of side effects to get seizures under control to help
Mm,
somebody's quality of life. Secondly, you're able to see if that medication is effective in a shorter amount of time. Maybe you can see if that medication is effective in 6 weeks instead of 6 months because you're having seizures every day or a few a week, for example. And so it's the silver lining of LGS is that really almost every medicine is available to you. And there are some companies that just make you try valproic acid and another one first, but then after that, the door is open.
okay. And can a general neurologist diagnose something like LGS, or would you suggest, I mean, would they need to be sort of transferred to a specialist like yourself?
I would say a general neurologist could diagnose LGS if they were aware of the criteria and the EEG reports, which would not have likely been reported by them, would have been reported by an epileptologist if it was clear that it met the criteria for LGS on the EEG reports. Sometimes it's not so clear. And the specialty centers like Connecticut Children's or seeing an epileptologist, you're likely to get an LGS diagnosis a little bit sooner.
Mhm.
And then in addition, there is the ability to think about some of the other things that a general neurologist might just think, okay, well, this is LGS. Okay, you're always going to have seizures. Let's try a few different medicines. But they wouldn't necessarily think about vagus nerve stimulation. They wouldn't necessarily think about new devices that we are thinking about off label, a DBS, an RNS, a corpus callosotomy. Those are things where you should have some benefit of a surgery center, an epilepsy center that can do surgery, and also think about ketogenic diet therapies for these patients as well.
All right. Yeah. So needless to say, I mean, I guess if somebody, if a mom or dad is taking their child to a general neurologist and they're still having seizures and they're not really getting a diagnosis, it might make sense then at that point for people to know that they can be sort of sent to a specialist where they might
Absolutely.
get
Yeah.
more information. Yeah.
Yeah. And it's very appropriate to start with a general neurologist too. And then when you reach a point where you feel like we're up against the wall, up against that
Right.
person's knowledge, then it makes sense to transfer or at least get a second opinion at a bigger center.
Right.
Nobody has all the answers, including in
Right.
LGS. About 25% of the time, we don't know, despite our best knowledge and investigations.
Mm, right. Well, thank you so much. I just love the way that you presented that in a way that was easy to understand and just so, I don't know, you covered, I feel like everything that you would need to know. But if people do have any additional questions for Dr. Worden, feel free to reach out to us and we can certainly connect you to Connecticut Children's as well if that is something where you are looking for a treatment provider. This has been recorded, and so this will be made available on our website for people to listen to again or to even to send to others that may benefit from the information. So if there are no further questions, we will go ahead and close. And thank you for attending, and thank you, Dr. Worden, for presenting tonight.
Thank you. Bye-bye.
Have a good night, everyone.